Hey everyone, and welcome back for another deep dive. As nurses, you're going to be looking at a lot of eyes, so we're going to take a deep dive into the eye
Oh, absolutely.
today.
It's fascinating.
So we're going to cover the anatomy, the physiology, and how to conduct a thorough eye exam.
Yeah, get ready for a lot of cranial nerves.
Cranial nerves, all that good stuff.
Yeah.
Okay, so let's start with the basics eye anatomy. We've got the white sclera. The iris gives the eye its color, the pupil, which is that window that lets the light in.
It's like the aperture of a camera.
Yeah, and then that conjunctiva that gets all bloodshot when we've had a long day.
Or had too much coffee.
Yeah, or had too much coffee or haven't had enough coffee, whatever it is.
Right.
So why are these structures so important?
Well, each part is perfectly designed for its function. I mean, the sclera, it helps maintain that shape of the eye, right? And then the iris controls the size of the pupil, so it can regulate how much light's coming in, like you said, just like a camera.
Yeah, and that's really important because you don't want too much light
It's very sensible.
coming into the eye.
Yeah.
And we can't forget the orbit, that bony socket that surrounds the eye.
Ah, yes, protection.
Protection, that's right.
Very important.
And then we've got eyelids and eyelashes to keep that dust and debris out.
It's like a natural screen,
Yeah.
right?
And speaking of the eyelids, we can't forget those little meibomian glands.
Right. They produce the oil that keeps the tears from evaporating.
It's like the moisturizer for our eyes, basically.
It is. It's the oily layer of the tear film.
Yeah. Okay. So speaking of tears, I'm curious about that because I know they keep our eyes lubricated. But what else do they do?
So many things.
Is there more to it than that?
Yeah. So tears have a very important job. They actually have 3 layers. Did you know?
3 layers. I did not know that.
Yeah. So you have that oily layer from the meibomian glands that we were just talking about. Then you have the watery layer in the middle, which washes away all those irritants. And then there's a mucinous layer on the inside, which helps to spread the tears evenly across the eye.
Oh, wow. So it's much more complicated
That it is.
than I thought.
Yeah, it's fascinating.
So is understanding how the tears work important for nurses?
Oh, it's crucial. So when you're assessing a patient, you always want to consider their tear production, the quality of their tear film. If something's off kilter, then they might have dry eye, and dry eye can be really uncomfortable.
Yeah, that makes sense. Okay, so let's move on to how we actually see. So we know that the lens plays a key role in focusing the light. But how does that actually work?
So the lens, it's suspended by these little ligaments called zonules.
Okay.
And it can change shape to focus the light on the retina.
So the lens kind of adjusts itself to make sure that we get a clear image, whether we're looking at something close up or far away.
Exactly. It's called accommodation. And that's how we can see at all these different distances. And when accommodation doesn't work properly, that's when you get things like myopia, which is nearsightedness, or hyperopia, farsightedness.
And that's what we correct with our glasses or contacts.
Exactly.
Yeah, okay, cool. So what about all the fluid inside the eye? Because I remember learning about something called aqueous humor.
Yeah, so the eye has 3 chambers filled with fluid. There's the anterior and posterior chambers right in front of the lens, which contain that aqueous humor. It's constantly being produced and drained, which helps to maintain the shape of the eye and provide nutrients to the cornea and the lens.
So there's just this constant flow of fluid happening in the eye.
Right, and that flow is really important because it regulates intraocular pressure, and if that drainage system gets blocked, the pressure can build up, and that's how you get glaucoma.
Glaucoma, that's the one that can damage the optic nerve.
Exactly, and lead to vision loss, so early detection is really important.
Okay, so we've talked about the front of the eye, but what about the back of the eye? I remember the retina, the optic nerve, all that stuff a little fuzzy for me.
Yeah, so imagine you're peering into the back of the eye with an ophthalmoscope. What you would see is the optic fundus, which is the retina, the blood vessels, the optic disc, which is where the optic nerve exits the eye.
So when we look through an ophthalmoscope, we're literally looking at the inside of someone's eye.
You got it. It's a really cool view. You can see the macula, which is the central part of the retina, and it's responsible for sharp, detailed vision. And inside the macula is the fovea, which is the very center and the point of our sharpest vision.
It's really incredible when you think about everything that's packed into that tiny space.
It is.
And if I remember correctly, the retina is where the light signals are converted into electrical impulses that are sent to the brain.
Exactly, like the film in the camera.
Right. Okay, so light hits the retina, and then those signals travel along the optic nerve to the brain where we actually perceive the image.
That's a fascinating journey to the visual cortex, which processes the information.
Yeah, and it all starts with that tiny little eye.
Right.
It really is amazing.
It is.
Can we talk a little bit more about the optic nerve? Because I know it's important, but I don't really know why.
Well, the optic nerve is the only connection between the eye and the brain. It's like a high-speed cable. And fun fact, we all have a blind spot where the optic nerve exits the eye.
We have a blind spot.
We do.
So there's a part of our visual field that we can't see.
There is. But don't worry, our brains are so smart, they fill in that missing information using input from the other eye and our understanding of the world. We don't even notice it.
Oh, wow, that's really interesting. Okay, so we've covered the outside of the eye, the lens, all the fluid, the retina, the optic nerve. What's next?
Let's talk about pupils.
Ooh, the pupils.
They're not just those black circles in the center of our eyes. They can tell us a lot about a patient's neurological status.
Oh, okay, so how can the pupils tell us all this?
Well, because of the pupillary light reflex, when you shine a light into one eye, the pupil constricts. That's the direct response. But the other pupil constricts too, even though the light's not shining in it. That's the consensual response.
So both pupils react even when we only shine the light in one eye.
Exactly, and it's a pretty complex pathway. It involves the optic nerve, which carries the signal to the brain, and the oculomotor nerve, which controls those muscles that constrict the pupil.
So if we see like a weak or delayed pupillary response, that could be a sign that something's wrong.
Yeah, something's not quite right along that pathway.
Okay, got it. So there's another pupillary reaction called the near reaction.
Right?
What is that?
That's when the pupils constrict when we focus on something close up.
Oh, yeah, I remember that.
Yeah, and the eyes converge, they turn inward, and the lens accommodates to focus on that near object.
So it's like a whole coordinated effort
It is.
to look at something close up.
It is.
Okay, and I know we've talked about some muscles already, but are there muscles that control how the eye moves?
Yeah, the extraocular muscles, we have 6 of them.
6.
Yep, and they control all the movements of our eyes, up, down, side-to-side rotation.
Wow, 6 muscles, that seems like a lot.
Yeah, they're controlled by 3 different cranial nerves, the oculomotor, the trochlear, and the abducens. And they all have to work together in perfect harmony to make sure our eyes move smoothly and in sync. That's called conjugate gaze.
Conjugate gaze, so that's what's keeping our eyes from going in different directions.
Exactly, and if one of those muscles is weak or paralyzed, you can get diplopia or double vision.
Oh, I see. Okay, so we've got the outside of the eye, the lens, all that fluid, the retina, the optic nerve, the pupils, the extraocular muscles, they're all working together.
It's a miracle.
It's amazing.
It is.
So now that we've kind of got the basics of the anatomy and physiology down, are we ready to talk about the eye exam?
I think so.
Okay, let's do it.
Let's put this knowledge into practice.
All right.
All right. So let's jump into that eye exam because, like we said, it's one of the most valuable tools you have as nurses.
Okay, so where do we begin?
Well, the first thing we always want to assess is visual acuity, how clearly the person can see.
Okay.
And for that, we use the Snellen chart.
Oh, yes, the Snellen chart with all the letters.
The one with the letters that get progressively smaller.
Yes, I remember that.
You know, standing 20 feet away, cover one eye at a time, read the smallest line of letters you can see.
Right. And they're supposed to be 20 feet away from the chart.
Exactly.
Okay, and making sure the room's well lit.
Absolutely. Make sure you can see.
And document everything accurately.
Always important.
Okay, so if a patient can read the line designated as 20/20, that means that they have normal vision.
That's right, 20/20 vision. So the first number represents the distance the patient is standing from the chart, and the second number represents the distance at which a person with normal vision could read that same line.
Okay, so if someone has 20/40 vision.
That means they can see at 20 feet what a person with normal vision can see at 40 feet.
Okay, so a higher second number.
Worse vision.
Means worse vision. Got it.
Right.
Okay, so visual acuity, that's just one piece of the puzzle. What do we do next?
Well, next we want to assess their visual fields, which is the entire area a person can see while looking straight ahead.
Okay, I think there was something called the confrontation test that we learned about.
Yeah, the confrontation test. Easy way to compare your visual fields to the patient's. So you're facing the patient about an arm's length away, cover one eye at a time, and bring your finger in from the periphery and see if the patient sees it when you see it.
Okay, so you're basically looking for any areas where the patient might not be seeing what you're seeing.
Exactly. Could be a sign of blind spots or other visual field defects.
Which could mean problems with
the optic nerve or the brain.
Oh, wow.
Yeah. So simple tests, but a lot of information.
Yeah, very cool. What about color vision? How do we test for that?
Color vision, we use those plates with the colored dots that form numbers or patterns.
Oh, yeah, I remember those.
Yeah, pseudo-isochromatic plates.
Yeah, and some people can see the numbers and some people can't.
Exactly.
It's so weird.
It's really cool. It's important to test for color vision, especially if there's a family history or if you're worried about optic nerve disease. Certain medications can affect it.
Okay, yeah, that makes sense. So while we're doing all this, while we're, testing visual acuity, visual fields, color vision, what else are we kind of looking at?
Right. Well, we want to look at the overall appearance of the eyes and the surrounding structures.
Okay, like what are we looking for specifically?
Well, look at the position of the eyes. Are they aligned properly? Is there any deviation? Observe the eyelids, any drooping, swelling redness, and also check for any abnormal protrusion of the eyeballs, which could be a sign of thyroid disease.
Oh, interesting. Okay, so really we're just looking for anything that looks out of the ordinary.
Exactly. Subtle clues can give us a lot of information.
Yeah, that's really cool. All right, so we've looked at all the stuff around the eye. What about the structures of the eye itself?
Right. So let's start with the conjunctiva and the sclera.
So we're inspecting like the whites of the eyes and that membrane that covers them.
Exactly. Use your pen light to illuminate the conjunctiva and the sclera. Look for redness, swelling, any discharge discoloration. A yellowish tint to the sclera could be a sign of jaundice.
Oh, right, which could indicate a liver problem.
Exactly.
Wow, it's amazing how much the eye can tell us about the rest of the body.
It really is.
Okay, so after the conjunctiva and sclera, what's next?
Well, then we move on to the cornea, that clear dome-shaped surface at the front of the eye.
Okay, so we're making sure there's no, like, scratches or abrasions.
Right, you want it to be clear and free of any of that. And also look for any opacities, cloudiness that could be a corneal scar or even a cataract.
Oh, and cataracts affect the lens, right? So how do we check for that?
For the lens, we can use a technique called transillumination,
Okay.
shining a light from the side of the eye to see how clear the lens is. If it's cloudy, that could be a cataract, especially in an older person.
So really anything that might obstruct the passage of light through the lens.
Exactly.
Okay, cool. So I think this leads us to pupils.
Yes, pupils.
I'm ready.
One of my favorite parts of the exam.
Yeah, so what do we look for when we look at pupils?
Well, remember that pupillary light reflex we talked about?
Yes?
Time to put that knowledge into practice.
Okay.
First, check the pupils for size, shape, symmetry.
Okay, so what's normal?
Normal size is usually between 2 and 4 millimeters in diameter. They should be round and equal in size.
Okay, so if the pupils are different sizes, that's when we start to worry.
Well, it could be a concern. We call that Anisocoria, unequal pupils. It could be benign, but it could also be a sign of something more serious.
Okay, so we're noting that down for sure.
Absolutely.
How do we test the pupillary light reflex?
Okay, so dim in the lights a little bit, ask the patient to focus on a distant object, then shine your pen light into one eye and observe the response, both direct and consensual.
And just to remind everyone, the direct response is the constriction of the pupil that's being illuminated, and the consensual response is the constriction of the other pupil.
Exactly. You want a brisk and equal constriction of both pupils. If it's sluggish, delayed, or absent, that could be a problem.
Got it. Okay, and then what about the near reaction? How do we test for that?
Okay, for the near reaction, you hold your finger or a pen light about 10 centimeters in front of the patient's nose and ask them to focus on it. Watch for pupillary constriction, convergence of the eyes, and accommodation of the lens.
So all three of those things should be happening at the same time.
All at the same time. That tests the ability of the eyes to focus on near objects.
Okay, cool. So I think we're ready to move on to the muscles that control the movement of the eyes.
Right, those extraocular muscles.
Yeah.
So we want to assess how well they're working together.
Okay, and how do we do that?
We test the 6 cardinal directions of gaze.
Oh, yeah, I remember that. We move our finger in kind of like an H pattern.
Exactly, you got it. Have the patient follow your target with their eyes, keep their head still, and watch for any limitations in movement, any nystagmus or lid lag.
Can you just remind me what those are again?
Sure. So nystagmus is that involuntary rhythmic movement of the eyes, kind of like a shaking or jiggling. It can be normal if they're looking in extreme gazes, but if it's present in primary gaze, that could be a problem.
Okay, and what about lid lag?
Lid lag is a delay in the upward movement of the eyelid when the patient looks down and then back up.
Oh, okay.
Could be a sign of thyroid eye disease.
Interesting. So just those little subtle movements can tell us a lot.
A lot.
Yeah. Okay, so I think that brings us to the ophthalmoscopic exam.
The grand finale.
I'm a little intimidated by this part.
It's intimidating at first, but the more you practice, the easier it gets.
Yeah.
Just relax and practice. The key is to get a clear view of that optic fundus, the retina blood vessels optic disc.
So we're really looking deep inside the eye.
Deep inside.
Okay, so what's the first thing we should look for?
First thing you'll see is the red reflex.
Okay.
That orange glue that fills the pupil when you shine the light from the ophthalmoscope. It's your welcome sign.
Okay, the red reflex, got it. What if we don't see it?
If you don't see the red reflex, that could mean something's blocking the light pathway, a cataract, retinal detachment, even a tumor.
So it's really important that we see that.
Very important.
Okay, and once we do see the red reflex, how do we find the optic disc?
You can follow a blood vessel back to its origin at the optic disc where all those nerve fibers converge to form the optic nerve.
So we're looking for that round, pale area where the blood vessels seem to kind of disappear.
Exactly. And then take a good look at the color, the shape, the size of that central cup. Look for any swelling or blurring of the disc margins, which could indicate papilledema.
Okay.
That's a serious condition caused by increased pressure in the brain.
Okay, so again, we're looking for anything that's kind of out of the ordinary when it comes to the shape or the color.
Exactly.
Okay, cool. So after we've looked at the optic disc, what do we look at next?
Well, moving out from the optic disc, we'll examine the retinal blood vessels, the arteries and veins.
Okay, and what are we looking for when we look at those?
Look at their color, their size, how they cross each other. In hypertension, you might see narrowed arteries. And in diabetic retinopathy, you might see microaneurysms, little bulges in the capillaries.
So we're looking for anything that kind of deviates from what we would consider normal.
Exactly. And then finally, you wanted to scan the entire retina looking for any unusual spots, lesions, or hemorrhages.
And what are some things we might see?
Well, you might see cotton wool spots, which are fluffy white patches.
Okay.
Hard exudates, yellowish deposits, and then drizzen those yellow deposits that you see in macular degeneration.
Okay, so we're just making sure that nothing looks out of place.
Yeah, if you see anything unusual, document it clearly and consider referring the patient to an ophthalmologist.
Okay, good advice. So we have covered a lot of ground.
We do.
It seems like a very thorough exam.
It is. It's very thorough, but very valuable.
Yeah, for sure. I think we need to talk about how to document all of this.
Absolutely. Clear, concise documentation is essential so other providers know what you found.
Okay, so what are some key tips for good documentation? Be specific, use the correct terminology, and paint a clear picture. For example, instead of saying pupils normal, you would write pupils 3 millimeters, bilaterally round, equal and reactive to light direct and consensual responses, brisk. Okay, so we're being really specific.
Very specific.
About the size, shape, and reaction.
Exactly.
And what if we find an abnormality? How would we document that?
Describe its location, size, and appearance in detail. So if you saw a corneal scar, you might write small linear white corneal scar located in the inferior temporal quadrant, approximately 2 millimeters in length.
Okay, so really descriptive.
Be descriptive.
And specific.
Use good terminology so other providers understand what you're talking about.
Yes, absolutely. So I'm feeling a lot more confident in my ability to do an eye exam.
Good.
But before we move on, is there anything else that we need to cover when it comes to the eye exam?
Well, we've covered the main components, but there are a few special techniques that can be helpful in certain situations.
Okay, I'm excited to learn about those. All right, so the special techniques, what are they?
All right, well, let's start with assessing eye protrusion, proptosis or exophthalmos.
Yeah.
So
That
remember,
could be a sign of thyroid eye disease.
it can. You're standing behind your seated patient, gently lift their eyelids, and compare how much their eyes protrude.
Okay.
If one's more than the other, or if it seems excessive,
Got it.
that gives you a clue.
So we're looking at each eye individually, and then we're also comparing them to each other.
Exactly, symmetry.
Okay.
Another technique, checking for a blocked tear duct,
Oh, yeah.
which can cause excessive tearing.
Okay.
This one's a little more hands-on.
Right.
You gently press on the lower eyelid near the inner corner of the eye by the nose.
Is this the part where we might see some, fluid
You might,
regurgitating?
if fluid comes back out of the puncta, that suggests a blockage.
Yeah, okay.
Not the most glamorous,
No.
but important.
Okay, what about averting the eyelid?
Ah, yes.
I've heard that's a good technique if we think something's stuck in there.
Exactly. If you suspect a foreign body, carefully flip that upper eyelid inside out. It allows you to inspect the underside.
Okay.
You can use a cotton swab or a small tool.
Yep.
But be very gentle.
That one seems like it would take some practice.
It does take practice.
Okay. What about the swinging flashlight test?
Ah, the swinging flashlight test.
I know it's to assess the optic nerve.
Yes, helps us detect optic nerve damage
Okay.
by observing how the pupils react to the light.
Okay.
Shine the light into one eye, quickly swing it over to the other eye, and watch for any differences in the pupillary construction.
So if one constricts and the other one doesn't,
Or if one is slower,
that could be a sign of a problem?
could be a sign of a problem.
Okay. All right. So we've covered those special techniques. Now back to documentation, because I know it's really important.
Some important, clear, concise documentation is key.
Right. So we want to be very specific when we're talking about what we see.
Use descriptive language and avoid vague terms.
Okay. So instead of just writing pupils normal.
Right. Give more detail.
Okay.
Pupils 4 millimeters, bilaterally round, equal, reactive to light direct and consensual responses, brisk.
Okay, so we're being specific about the size, the shape,
Everything.
the reaction.
Into the details.
Okay, and what if we see something abnormal, like a corneal scar that we were talking about?
Describe its location, size, appearance. So a small linear white corneal scar located in the inferior temporal quadrant, approximately 2 millimeters in length.
So specific, descriptive.
Precise.
Location.
Make sure other providers can understand what you saw.
Absolutely. Well, this has been an incredible deep dive into the eye.
We covered a lot.
We really did. I feel a lot more prepared to go out and do eye exams now.
Good. I'm glad to hear it.
So any final thoughts or advice?
Just remember, the eye is a fascinating organ. The more you learn, the better you can care for your patients.
Absolutely. To all our listeners out there, keep those ophthalmoscopes handy and keep learning. We'll see you on our next deep dive.